All right, good afternoon, everyone, and welcome to this seminar, which is being provided by the School of Pharmacy in commemoration of World Diabetes Day. Now, it comes at an appropriate time because a significant proportion of our population would have been affected by hyperglycemia over this weekend and expected to continue during the Christmas season. So, as you're aware, World Diabetes Day was created in 1991 by the International Diabetes Federation and the World Health Organization. This was done in response to growing concerns about the escalating threats, the health threats that were posed by the high incidence of diabetes. The World Diabetes Day became an official United Nations Day in 2006 with the United Nations resolution. It is marked every year on November 14th, the birthday of Sir Frederick Banting, the Coke discoverer, along with Charles Best in 1922. They discovered insulin. So, World Diabetes Day is the world's largest diabetes awareness campaign, and it reaches a global audience of over 1 billion people in more than 160 countries. The School of Pharmacy inspired by promoting this event as an educational activity for our students, our healthcare workers throughout Trinidad and Tobago, and the Caribbean at large. We have three highly distinguished speakers for you this afternoon. But before we go to them, I'll introduce them to you in a short bit. I will ask Dr. Rajiv Dahia, the director of the School of Pharmacy, to give you greetings on behalf of the school. Dr. Dahia?
Yeah. Good afternoon, all. So, on behalf of School of Pharmacy, I welcome all the speakers and attendees in this World Diabetes Day webinar. Today, with us, eminent speakers are there from different organizations and countries. We uh, we have Professor Dinda from India and Professor Tilak Singh from FMS UV St. Augustine, along with the President of Diabetes Association of Trinidad and Tobago, Mr. Andrew Delu. Welcome, all of you, sir. So, as you know, diabetes is a hot topic of interest. And if we will check the global concern, 1 in 10 people are living with diabetes. And I hope our speakers will address the issue well in different aspects of diabetes, and it will be helpful for all. Thank you. Welcome again.
Thank you very much, Dr. Dahia, for those welcoming words. So we'll get right into it. Our first speaker is Mr. Andrew Danu. He is a lecturer in biochemistry at the School of Nursing, the Faculty of Medical Sciences. He's also associated with the Department of Food, Faculty of Food and Agriculture, and he's also a teaching assistant at the Faculty of Science and Technology, the Department of Life Sciences. He's the youngest member on the Diabetes Association, and he's currently the president of this association. At the Diabetes Association of Trinidad and Tobago, he has spearheaded several national diabetes screening and educational projects, which include the Diabetes Association of Trinidad and Tobago 17, the National Primary School Diabetes Quiz, and various cooking competitions. Mr. Danu is currently a doctoral candidate at the University of the West Indies St. Augustine campus, pursuing a PhD in clinical biochemistry and diabetes research. His work involves the investigation of novel, non-invasive methods of diabetes screening and testing, which is of particular interest in screening diabetes risk. He is an advocate for health and fitness and is working on numerous intervention programs geared towards overweight children and their parents through dietary and activity modification. Mr. Danu works as a research assistant or project coordinator on various projects with Johns Hopkins University under the Trinidad and Tobago Health Sciences Initiative, and he has published numerous papers at various presentations and conferences, the Child NCD and CAFA. Without further ado, I give you the president, the youngest president of the Trinidad and Tobago Diabetes Association, Mr. Andrew Dano. Mr. Dano, welcome.
Thanks, Dr. Janki, and welcome everyone. And thanks to the School of Pharmacy for having the Diabetes Association represented here at your seminar. And it's appropriate because, of course, this is World Diabetes Month, and yesterday, in fact, World Diabetes Day. So let me just start to share my screen. So the Diabetes Association would have been founded some 30 years ago, and the organization has been growing ever since. And to date, we have about 5,500 members. The association, although quite small still in its staff, and that we only have really 2 active staff members or paid staff members, have hundreds of volunteers around the country. And we do the work of the association. So I myself am a volunteer. All of the members of the board are volunteers, and then we have volunteers in all of our branches around the country. The aim of the association is threefold. So one, we focus on education. So education for persons living with diabetes, education of persons who may be affected by diabetes and who want to get information so that they prevent diabetes. Advocacy, so we are the voice for the voiceless, so the voice of persons who have issues related to diabetes and need help to express themselves. So the association is big on the advocacy for persons and advocating for persons living with diabetes, advocating for the needs of persons and advocating for prevention. Research, of course, is a huge part of the association, and I myself, being a researcher, has pushed the mantle of research in the organization, and we have, for the last few years, delved into a few projects, which, again, we're trying to answer questions. And of course, research, as you all would know, is basically getting answers for questions that no one has as yet. And those answers, especially for Trinidad and Tobago, should be answered by people in Trinidad and Tobago. So the research aspect of the association is huge. And of course, with that research, we collaborate with University of West Indies, with other academic institutions in Trinidad and Tobago, in the Caribbean and around the world. On top of that, the association also has a heavy screening component, in that we screen for persons, or we screen persons who may be at risk for diabetes, and we also would do testing so that we aid in diabetes management. So I'll talk a little bit about that in the presentation. The association has one head office, so the head office is located in Chaguanas, and we have one sub office in Arima, and then we have 20 branches around the country. So these branches are essentially support groups. They're not brick and mortar locations, but they are in the health centers in all of these regions around the country. And there are a few branches that we are about to start, but of course, our branches are in essence social groups, and that has put, or rather, the introduction of COVID-19 into our society and our country has kind of put a huge damper on the way the association has been run. But I'll talk a little bit about how that has been a huge disadvantage, but also it has encouraged the association to push forward and do so much more. So I'll talk a little bit about the programs that we have started in the association, because I want to show you all how the association is there to help persons living with diabetes, and the things that we have done, the things that we are doing, and the things that we want your help with. Because of course, the association is a people-centered organization. We are a group of persons who all volunteer to do this work. So one of the main projects that we are proud about is the HbA1c program, or the program we call Know Your A1c. And for persons living with diabetes, unfortunately, a lot of persons in Trinidad do not know what HbA1c is, nor do they even know their number. So as persons who are living with diabetes, at least they should know their HbA1c. So we've launched a program, and we started it with training. So we were able to get point of care HbA1c machines donated to us, and we were able to start a training program where we trained essentially 150 persons around Trinidad and Tobago, and we're still continuing training today because we've started with the Lions Clubs of Trinidad and Tobago and our members and volunteers, and then we rolled out screening projects throughout the country, and that was early last year we began, and then we went on to the middle of the start of this year when we kind of had to hold things, when we kind of stopped all of our activity because of course we wanted to keep our members safe. So the HbA1c program would have been something that we would have started to not only get persons more knowledgeable about A1C, but also provide the test at a reasonable cost. Because at the association, everything that we do for persons is either free or the lowest that we could possibly get it to be. So the A1C, we charge $80 to an HbA1c test, which again is point of care. And then we do lipid panels as well. And we have special prices for children with diabetes. So we've started that a while ago, and we continually do the HbA1c testing. On top of that, we also have started recently diabetes foot screening. So at the association, at the head office, we do diabetes foot screening free of charge for persons. And of course, if there is need for follow-up, then we recommend them to the hospital, or we recommend them to another professional that can give them the help that they need. We've also started diabetes retinopathy screening, or diabetes eye screening, which involves retinopathy screening. And we've done that with a program with the Trinidad Eye Hospital. We've started it last year when we did it at the head office, and then we started to branch out. And for this month, World Diabetes Month, or Diabetes Awareness Month, we've gone into 10 communities, which I'll tell you about. Of course, at the heart of the association is the volunteers, as I said, but of course, these need to be trained. And here's just an image of a few of our nurse volunteers. So these are our fourth-year student nurses who volunteered from UWI to learn how to do HbA1c and then go out into the field and do HbA1c screening. The association also has our Diabetes Attention Center, which as part of it would be the screening, but also we have counseling services. So we have our nutritionists and nurses who all volunteer as well and are at the association and have or see patients by schedule or by appointment. And of course, it's something that we will be offering persons to aid in their diabetes management, because at the heart of what we want to also accomplish is complement the health system, or complement the public health system, and that patients living with diabetes that need to manage their diabetes often need a substantial period of time spent with a medical professional or someone who could be able to give them the advice that they need. Unfortunately, that can't happen as, or it doesn't happen as it ought to, and especially now, where the time that you're allowed to see a person, the time that you have to see a person or patient is so limited. So of course, the organization has been complementing that service for quite some time. And then I'll also tell you about how we have shifted that. In the image here is just, is our patron, Mrs. Nicole Diagriffith, who has supported the organization for the last couple of years. The organization also has a lot of events and activities, and of course this was last year. This was exactly a year ago last year, and last year for World Diabetes Day. Well, of course for the month we had a lot of activities, but for World Diabetes Day, every one of our 20 branches did activities in their areas. So this was our San Fernando branch doing a lecture series and exposition at Gaucho Mall. And then on that day, we would have reached close to 10,000 people, either through testing or just through interactions. So it was a massive effort for us. Of course, we weren't able to do that today in person, well, yesterday in person, but of course, we've readjusted and we've shifted a lot of our activities virtually. This was one of our main activities that we had last year, or run that 5K. And we started it last year. We actually had about 800 persons attending. This year we were aiming for 3,000. And we started planning for the event since November of last year. But of course, because of COVID-19, we had to suspend that. So we actually planning now for 2021. The association also works quite a lot with our children with diabetes. And we have, for the last 16 or 17 years, had a children with diabetes camp. Some of these camps would have been live-in camps, and some of these camps would have also been day-long camps or day camps. And we've had camps for quite some time. And this year, we've had to have a camp because, of course, we didn't want to leave our children out. So we actually did a virtual camp. And our virtual camp meant that we would have prepared packages and sent it out to 36 children around Trinidad and Tobago. And they had individual presents or packages that they had to open every day. And we were live right in the room that I'm sitting here. And we had presenters showing how to craft and giving them educational activities. So it was as though that they didn't really miss anything, in that they were safe at home and they were able to participate in our camps and learn how to take care of their diabetes. Of course, type 1 diabetes has been at or on the minds of the association for quite some time. But in more recent times, children living with type 2 diabetes or pre-diabetes has come into the fore. Because of course, we have seen the rise in obesity, and with the association noticing that, and of course, noticing the trend that of course, with persons or with children or obese children, overweight children, the more that we have, of course, it may lead to having more obese or overweight and persons with diabetes as adults. So we've started our teen lifestyle camp, which we did last year. Of course, unfortunately, we couldn't do this year because this really involves one-on-one interactions with these children. So we started our teen lifestyle camp last year, and we had close to 40 children who participated in 3 days of activities, which centered around nutrition and exercise and stress management. These are some of the children here, and we were, some of the counselors from UE, so some UE students would have volunteered, and of course it was supported by the Ministry of Health. So it's something that we want to expand, and this year we were actually planning to have it throughout the country. This event was in Hoover. The event next year hopefully should be around the country, or multiple events around the country where we could reach more children. Of course, the advocacy, as I spoke about in the association, is only accomplished with persons who can speak up. And of course, I've been speaking up, and I've been trying to get support and raise funds, because of course, funding is something that is very important to the organization. Although we're not paid, we need funds to do the work that we do. We need funds to print things, and we need funds to go places, to get the equipment that we need. And of course, we need funds for the building. The building I'm sitting in today is over 80 years old, and it's crumbling. So we do have our advocates, two of whom are our patron, Mrs. Nicole Dyer Griffith, and our champion, Miss Hema soon. And then we have quite a lot of new ones coming on, and that will be announced this month. Artists and persons with diabetes who have accomplished quite a lot. So we will be having quite a lot more of that. And of course, we do have a significant impact in the media, and we always try to comment on anything that is relevant, try to make meaningful comments, and also comments that are backed by data. And that's something that I wanted to mention in a bit. Of course, the association does need more help, and we do that through our volunteer recruitment. So this was one of our first batches of volunteers that we had last year. And since then, so this was just our first batch. Since then, we've put out a call, and actually this was in January of this year. We put out a call, and in 3 days we had 700 people responding to us saying that they want to volunteer and help the organization. We did plan volunteer training programs, and this was the program that we planned. We put together manuals, we had T-shirts. And then, of course, the coronavirus came to Trinidad, and we had to cancel everything. But of course, all of those volunteers are still there with us, and they've been trying to help as much as they can virtually. But our hope is that in January of 2021, we can actually meet more of them and train them to go out into the field and do more testing and reach more persons and educate persons in communities. So of course, the volunteers, we need them to do outreach, and of course, we want to build our research capacity, and we need administrative staff. do more projects, and of course, more fundraising. This month, as I told you, is Diabetes Awareness Month, and yesterday was World Diabetes Day. And Satish would have told you all why we celebrate World Diabetes Day. And of course, around the world, persons would have been celebrating. Yesterday for us was also Diwali. So it was twofold for us in that we incorporated some information that maybe may have been relevant for persons around the Diwali time. And hopefully not too many people today are waking up with elevated blood sugars. So we were doing that yesterday. And of course, we have our online challenges that we would have launched yesterday as well. So this is our month of activity, our month-long diabetes awareness activity calendar. And as I mentioned, we would have had a diabetes eye screening program in 10 communities, and 4 so far. The next one is going to be in Faizabad on Monday, and then with Point Fortin and Tobago and Moruga. So our aim is to reach 500 persons who are living with diabetes, who have never had a diabetes eye screening before. And of course, our aim is to capture persons who may have diabetic eye diseases, which of course is reversible if caught in time. Sorry. Our aim is 500 persons, and so far we've had about 450 appointments made. So we just have about 50 more, some of them in Tobago and Moruga. So we're hoping to get some more persons there as well, so that we can really complete our mission and reach these persons. And of course, at the end, we'll be able to tell how many of these persons really did need an intervention, and we directed them to the help that they need. The association has also, as I said, this is really the only in-person thing that we're doing, or on the field activity that we are doing for the month. Everything else is online. And the coronavirus has set back the organization significantly, but also it has opened us up to a lot of opportunity and gave us the chance to do things we may have never thought that we could do. Many of our members are either elderly or have resisted technology for a long time. And now, of course, many of them or many of our groups have started WhatsApp chats and have Zoom meetings and things that they've never thought that they would have done before. So that, of course, opens the door to using technology to manage diabetes. Of course, in more developed countries, that would have been accepted easily before now in Trinidad. But of course, I think now in Trinidad, we are more accepting of technology because we have to use it. So we've put into place a lot of the activities using technology. So we're launching a new website, and this coming week we are launching a new website, mydatt.org, which would provide a lot of diabetes information and of course extend and link to some of our services available. One of which is our diabetes shop, the DATT shop, which we started a few weeks ago. And today we've had over 100 sales, or 100 unique sales, raising that's like about $15,000 in sales just in the course of a few weeks. And the reason we got that is because, of course, we offer items for persons living with diabetes all in one space that are the lowest prices possible. So most of the items, we don't even have markups on them, because our aim is just to get items to persons, get diabetes products to persons to their home, because it's free delivery when you purchase anything on the DATT shop in the time that they need it. So we'll be adding to that. We also have our magazine, which was due to come out a few months ago. It's going to come out in a few weeks, and of course it's going to be virtual, but also we're going to have printed copies that we're sending to members, and we're sending to organizations and doctors' offices. We have our telethon that is next week. The date here is wrong, but it's actually next week on the 27th. Following week on the 27th rather, and we're going to have this telethon in aid of this building. So we're trying to raise funds to renovate the building, because of course renovating the building means that we now have more space to do training and more of our activities. A couple of the things that we are most excited about, however, is our app, and I'll tell you about that quickly. So as I said, we would have had a few other activities, one of which would be our webinar, which is on the 22nd. We are teaming up with the University of West Indies School of Nursing, because the theme for this year's diabetes awareness is a nurse and diabetes. Of course, this year is the International Year of the Nurse, but the IDF has chosen the nurse and diabetes because we want to highlight the importance of the nurse in diabetes management. So the association is going to be working together with the University of West Indies and also University or New Birmingham City University in the UK, as well as Merck, who is involved in the project. And those invitations are going to go out from tomorrow. One of the activities that we have been doing for the month is the challenges, and the challenges replaces our 5K because, of course, we can't have persons meeting in public and gathering in public rather. So the challenges are a series of activities that we've posted on social media, and these activities encourage persons to become active and make healthy choices, and also show how much they care. So I can't reveal all of what the challenges are because the second one came out yesterday. First one, the active challenge, we had over 50 participants wearing blue and doing some activity. And then we gave prizes to them. Yesterday we launched a cooking challenge, and so far we've had 10 entries in the space of 2 hours or 2 or 3 hours. So we have a few days to get some more entries there, and I know that a lot of people will participate in that. So we're activating the population and helping them, well, one, become more aware of the organization, become more aware of diabetes, but also through our social media, able to drive or become more active and do things that create healthier habits in them. So I did tell you about our telethon, and our telethon is going to be on the 27th, and we partner with Gael to do the telethon, and of course Tattle and Tattle Life, who has committed to work with diabetes and taking up diabetes as its corporate social responsibility initiative, is working with the association quite substantially and has been for the last year. So we're working on this telethon, and we hope that all of you can tune in and become part of it. And this is really the project that I think, the DATT app is a project that I think, well, I am most excited about, and the association is most excited about, and this is going to be launched this week. We have been working for the past 7 months on this application. It's a mobile application which allows persons, there are lots of features on it, but the most important one is allows persons to manage their diabetes and keep track of their diabetes. So the diabetes logbook feature in it will allow persons to enter their blood sugars, blood pressures, A1Cs. They'll be reminded when they should do it. They'll also get prompts, or persons, their next of kin, or even their physicians can get prompts when their readings are either too high or too low. And of course, we could be able to track that. And in tracking that, of course, we're able to now get data for the population, which is very important. Because of course, for a long time, we don't have population-wide data of what has been happening. So that's just one of the things that the app can do. Of course, more would be our diabetes management, or rather our membership management, or volunteer database, or diabetes risk score, our diabetes education platforms, or DATT shop is available there, and a lot of diabetes education is going to be available on the application. You can even make donations on the application. So again, we've been working on it for quite some time, and there's nothing else like it. There are other applications that do or have parts of these features, but all these features we've pulled together in that this is what a diabetes association needs. And actually, we're going to be rolling it out in all of the other diabetes associations, or with all of the other diabetes associations around the Caribbean in a few weeks. So it's going to be an application that is around the Caribbean. Hopefully, we can integrate it into all of the other associations around the Caribbean, from Mexico, go down to Guyana. And so we're hoping that we have this integration happening. And of course, we are extremely excited about it. This is just an image of our diabetes ice cream program, which we would have had, and I told you all about it. So in conclusion, I just want to mention quickly about the statistics that we have in Trinidad, or the statistics that we have around the world. And according to the IDF, we estimate that there are about 400 million persons living with diabetes around the world. But the estimation, the projection is that that number would increase by 200 million more by 2035. So of course, within the space of 20 years, there will be an exponential increase. And we have been seeing that in Trinidad for quite some time. In the 60s, the first ever study on diabetes was done, and we had an estimated prevalence of about 2%, with about 2% of persons having impaired glucose tolerance or prediabetes. In 96, there was a study that reported about 11%. And then 2012, the STEP survey reported a prevalence of about 13%, with 20% impaired glucose tolerance, or what we could probably say as prediabetes. So at that point in time, you would have had about a 33% prevalence rate. But that's the last time that data was really collected as a representative sample of the population. Since then, projections have been made, and the IDF has been making projections. And according to the IDF Atlas, which came out last year, we have an estimated prevalence rate of about 16 or 13 to 16%. 13 to 16% puts us at about 200,000 people living with diabetes. And if you were to take an impaired glucose tolerance average of about 20 to 25%, then we get 300,000 persons living with prediabetes. So again, these 300,000 persons or more, could be more, and most likely it is, these 300,000 persons, if no intervention is taken in the next few years, or as soon as possible, then they will also become, or they will also have diabetes, or become, or develop diabetes, which of course we need to intervene, we need to stop. So this is what the association has been trying to do. And of course, more worrying for us is children living with diabetes. And there are many, as I told you, many more children who have now become diagnosed with type 2 diabetes and have prediabetes. And we've seen this for quite some time, because a study that we did and I participated in through Johns Hopkins about 6 years ago, we would have found that 1 in 3 children in primary schools, and this was in Point Fortin that we did this study, but I've seen many persons interpret it as having this ratio or this prevalence around the entire country, that 1 in 3 persons or 1 in 3 children in primary schools are either overweight or obese. And one of the main culprits, of course, is sugar and sugar-sweetened beverages. The ECC would have mentioned, this was in 2015, that Trinidad and Tobago, out of 187 countries, consume the most sugar-sweetened beverages than any other country in the world. 2.5 more times than any other Caribbean country. And of course, this is why we would have championed the reduction of sugar-sweetened beverages and worked with the Ministry of Health in reducing and eliminating sugar-sweetened beverages from school. So in closing, I just want to leave this picture with everyone. And this picture would have been, well, or this person would have been the biggest person in the world 100 years ago. And if this person walked down the street, everyone will turn their heads because there's no one else looking at them. And of course, you would know something is wrong with this person if there's no one else is looking like you. But if everyone else is looking like this, then this becomes normalized. And that is one of the problems that we have been seeing in society, that people don't think that they have a problem because they look the same like everyone else. And they may not think that something may be going on there and they need to get checked and they need to get the support that they need. We provide that support at the association, and most of which is free of charge. And as I say, no, people like that are all around the country, all around the world, and even in Trinidad here as well. So with that, I want to close and also say thank you for having us here, Dr. Janki and School of Pharmacy. And I ask that the attendees support the association by going to ticketbay.com/d/DATT and making some small contribution to the organization. I'll put the link in the chat as well after my talk. All right, so thank you. Thank you.
All right, thank you very much for that very insightful presentation on the role of the Diabetes Association. We heard about the education, promoting education for persons who are living with diabetes as well as persons who are at risk. We heard the role of the Diabetes Association in being the voice for the voiceless, the focus on research and the screening of patients, the very impressive Know Your A1C campaign, the 5K, and the Teen Lifestyle Camp. So thank you very much for that very insightful presentation in terms of the contributions of the Diabetes Association, what the Diabetes Association is making towards the promotion of education in Trinidad and Tobago. So we have a couple of questions that we'll look at in the chat box. The first question is, comes from Stephen Jeffrey. He says, can you indicate the contact information and location of the diabetes shop, Andrew, that you mentioned previously?
So the DATT shop is online and you could access it in many ways. One, you can access it through our Facebook page. You go onto our Facebook page and there's the first blue button at the top, visit shop. You click on that and it takes you to the DATT shop. You could also access through our app, which is going to be launched, as I said, next week, both on the Apple Store and the Google Play Store. And the third way is going directly to the link, which is plantingseeds.com/DATT shop. I'll put it in the chat for you all to get it.
Right. Thank you, Andrew. We have one other question that we could probably look at now before we move on. How can persons become involved with the Diabetes Association?
So you could either become involved as a member or as a volunteer. As a member, it means that, of course, you pay a subscription fee, but the subscription comes with it benefits to the organization and discounts and services available that are only exclusively available for members. As a volunteer, anyone can become involved and help the organization. All you need to do is contact the organization either through our Facebook or Instagram, just Diabetes Association Trinidad and Tobago, or you can message or you could call 6720864. I'll also put it in the chat, or email us at Diabetes Association or info@diabetesassociationtt.org, or you could visit our website, mydatt.org.
Okay, thank you very much, Andrew, for that. And I'm sure we'll have more questions coming in later for you. All right, so let's move on to our second speaker, and he is Professor Subhash Chandra Dinda. He's currently the professor and head at the Department of Pharmaceutics, the College of Pharmacy in Tirthankar Mahavir University in India. He has decades of teaching, research experience, including 16 years as the principal or director in the Faculty of Pharmacy in India and also abroad in Ethiopia. He has about 120 publications with over 1,100 citations. He has supervised and graduated 18 doctoral students. He has served in various capacities in organizations such as the Association of Pharmaceutical Teachers of India, the Indian Association of Pharmaceutical Scientists and Technologists, the Academic Council, University of Technology. He's also the editor-in-chief of the American Journal of Drug Discovery and Development and Science International. He has been awarded quite a number of awards, the first being the Gold Medal for BFARM in 1996, the Priyadarshini Indira Gandhi Award in 2005, the Arch of Excellence Education Award in 2005, the Raja Lakshmi Memorial Best Teacher Award in 2006, the Distinguished Teacher Award in 2015, and the Outstanding Scientist Award in 2019. So without further ado, let's go to Professor Subhash Chandra Dinda, who will speak to you about diabetes and drug delivery systems. Dr. Dinda, welcome.
Thank you. Thank you, Dr. Janki, for nice introduction to me. First of all, I'd like to thank the Diabetes Association, the president, Dr. Andrew, and the organizers for giving me the opportunity to interact with you with this World Diabetes Day. So I would like to start my presentation. I'll not take much more time on this introduction part. So shall I go for the sharing my screen?
Share screen.
Yeah. So good afternoon, everybody. First of all, I would like to welcome all of you to my presentation on role of pharmacist in diabetes management and drug delivery aspects. So coming to the objective of my presentation, to have an understanding on the diabetes and its complications, and how best a pharmacist can guide or help you in identifying the type 2 diabetes mellitus, that is non-insulin dependent diabetes mellitus, and manage it in a best possible way with and or without a drug therapeutic agent. So after my talk, you will be understanding the diabetes and its complications, goals of the diabetes management, and pharmacist role in the diabetes management, and preventive measures, that is non-therapeutic measures you can take for the managing diabetes, as well as you can take the drug therapy in managing type 2 diabetes with oral anti-hypoglycemic agents or the synthetic analogs, and the herbal remedies, some of the examples of herbal remedies which can be best utilized to manage the diabetes. Now, coming to the diabetes, first we should know what is diabetes. Diabetes is often referred by the physicians as a group of metabolic disorder in which the person has higher blood glucose level either because of insulin production is inadequate or body cells do not respond properly to insulin, or both the cases. Now, look to the global scenario. As per the WHO report, the number of people with diabetes rose from 108 million in 1980 to 422 million in 2014. The global prevalence of diabetes among adults over 18 years of age rose from 4.7% in 1980 to 8.5% in 2014. So between 2000 and 2016, there was a 5% increase in premature mortality from diabetes. So if you analyze this scenario, you can assess how diabetes is affecting at global level, maybe because of pollution, maybe because of food habit, or maybe because of stress-induced conditions. Recently, we are facing, as you all of you know, we are facing the COVID-19. Once you might have seen, once the people get the stigma that he has positive with the COVID-19, his blood sugar level rises like anything all of a sudden. So this is a very complicated situation to manage. Now the present scenario, how to manage the diabetes. So now if you see, there are two types of diabetes. I will emphasize on the diabetes, non-insulin dependent diabetes mellitus, because I will be concentrating on the diabetes mellitus. Diabetes mellitus is because of the insulin deficiency, or sometimes because of the insulin not unable to utilize by the body cells. Coming to the type 2 diabetes, it is also known as the juvenile diabetes. It is called insulin dependent diabetes mellitus. It occurs when the immune system mistakenly attacks and kills the beta cells of the pancreas. So no or very little insulin is produced by the body. In that cases, you have to go for substituting the alternates like insulin only. So it is an insulin dependent diabetes mellitus. And if there is no alternate, we have to substitute the insulin. But in case of type 2 diabetes, it occurs when the body cannot properly utilize the insulin that it releases by the beta cells of the islets of Langerhans of pancreas. That is called non-insulin dependent diabetes mellitus. Glucose builds up in the blood stream instead of being used as an energy. And if you look to the statistical report, this 90% population of the diabetes population is because of type 2 diabetes, that is non-insulin dependent diabetes mellitus. And type 1 affected only 10%. That's why I have decided here, this is in type 1 diabetes treatment includes the invasive process. So we generally try to avoid it, and generally we try to manage it with the non-insulin dependent, manage with the oral hypoglycemics. So that's why I am concentrating here on in my talk on the type 2 diabetes management. So diabetes mellitus, what is it? The diabetes mellitus is a metabolic disorder of the multiple etiologies. It is characterized by the chronic hyperglycemia together with disturbances of carbohydrate, fat, and protein metabolism resulting from the defects of insulin secretion or insulin action or both of it. Now, absolute or relative insulin deficiency causes disorders of metabolism, including carbohydrate, fat, and protein, leads to hyperglycemia, the blood glucose level increases, or glycosuria, that is the glucose available in the urine. Now, if you see the symptoms, how you can assess that the person may be showing the symptoms of diabetes, attacked with the diabetes. So the symptoms include weight loss. Suddenly you will find the person is losing weight. Suddenly you will find he is exhausted. If a little bit walking or exercising, you will be exhausted. And you will find blurred the vision. This vision is losing the vision, and frequent urination, maybe more in the night, or he will feel thirsty all the time, as well as he becomes hunger. He will feel hungry. So if any persons coming associated with these are the symptoms, then we can guess that he may be suffering from the diabetes. And you see the complications arised with the diabetes include the wounds in the foot that won't heal, leading to amputation. Then heart problem, heart disease will be aggravated, and sometimes it leads to the stroke in the brain, and sometimes kidney failure, and also blood vision, that is damage of the blood vessels in retina, which can cause the blindness. So these are the harmful effects caused by the diabetes. So if you see the diabetes, the warning system signs you can see and observe. With type 2 diabetes, the symptoms can be mild or absent, which includes frequent urination, excessive thirst, rapid weight loss, lack of energy. So I told this can be mild or absent. So in pre-diabetic cases, sometimes it may not be much visible to identify that yes, he already started attacked by the diabetes. Now, the goal of the management is to ameliorate the symptoms of the hyperglycemia, reduce the risk of the microvascular complications, reduce the mortality, and improve the quality of the life. So how can we improve the quality of the life? By the glycemic control therapy. How this glycemic control therapy means we have to bring down or manage the biochemical index in the blood, which includes, as per the, I put some of the limitations of the biochemical index as per the American Diabetes Association report, as well as American College, as prescribed by the American College of Endocrinology or the American Association of Clinical Endocrinology. So this glycemic blood level, that is hemoglobin A1C, should be less than 7% as per ADA, and as per AC, it should be less than 6.5%. Preprandial plasma glucose must be 70 to 130 mg per deciliter or 110 mg per deciliter as per the SE. Postprandial plasma glucose must be less than 180 mg per deciliter, or it may be within the less than 140 mg per deciliter. So if we try to bring down or control within this our biochemical index, the glucose level in the blood, then we may be able to manage the diabetes. So how, without therapy, without any medicament, or with medicament, or using both the methods, how can we best manage, or the pharmacist can help in controlling this? So pharmacist can help you in this way. The pharmacist can help in early detection and monitoring of the diabetes by checking your blood glucose in the pharmacy. The pharmacist can give advice regarding the best use of medicines, whether to take before or after or with food. So that is, it is important, before, after, or with food. That is the important, because we have to identify the level of your diabetes, which stage. Accordingly, there are different drugs act on different stages. We can prescribe that. Your pharmacist can help you choosing the right drug in right time, and thereby it can be best possibly managed. It's possible side effects, they can advise you, they can prescribe you storage conditions of the drugs and help you in managing the same. The pharmacist can also help to take your medicines as per the treatment schedule. So there are various type of insulin, and it's important to use the type and dose of the insulin prescribed to you by your doctor. But pharmacist can help you to use right insulin, right dose, right syringe, right injection techniques at right time. So these way the pharmacist can help you. The prevention of diabetes, you may include the non medication as well as medication. So in my in a non-medicated way, how can you manage? So it is the best way to go for adopting exercise and the dietary control. So dietary control plays a very vital role in managing the diabetes, and your pharmacist can help you in deciding the diets. So these 4 dietary changes can have a big impact on the risk of type 2 diabetes. Choose your whole grain and whole grain products over highly processed carbohydrates. So instead of taking the highly processed carbohydrate, you can choose the whole grain or whole grain products. Skip the sugary drinks and choose water, coffee or tea, maybe with less sugar or without sugar. Choose the good fats instead of bad fats, and limit red meat and avoid processed meat, and choose nuts, whole grains, poultry or fish instead. Means fish is made up of, composed of mainly rich with proteins, so it will help you to manage the diabetes instead of taking the red meat. So this is the chart, so thereby it can help you to manage. Now coming to the diet, you have to take the healthy eating, which includes, I already told you, water, drink water, tea or coffee with or no sugar, eat variety of whole grains, and then choose fish, poultry, beans instead of red meat. As per the Harvard School of Publication, this prescribed, they suggest this. Eat plenty of fruits of all colors, then more vegetables of different varieties, then use healthy oils like olive oil and canola oil in cooking or in putting salad. So thereby you can manage our diabetes. So coming to the non-pharmacological measures, means without drug, exercise plays a very vital role, and we have to adopt which type of exercise is best for us. That your pharmacist or a health expert can suggest you to choose this. So which include this exercise includes what kind of exercise is best, like aerobic exercise or resistance exercise. Aerobic exercise includes the continuous exercise such as walking, bicycling or jogging that elevates breathing and the heart rate. Now resistance exercise means exercise by using the instruments. So this resistance exercise involves brief repetitive exercise with weights or weight machines. If you decide to begin the resistance exercise, you should first get some instruction from a qualified exercise specialist or a diabetes educator. Now, what pharmacist can track you? This pharmacist to take your medication as prescribed by your doctor, reach and maintain a healthy weight through a healthy diet, add more physical activities to your daily routine, and help in control your ABCs, A1C the blood glycemic level, pressure, and cholesterol level, and kick the smoking and alcohol consumption habits to maintain your good health. Now, management of diabetes with the medications. So what medications we can take? As I told you, there are 2 types of diabetes medicines for the treatment of diabetes. For one is insulin dependent diabetes mellitus, and the other one is non-insulin dependent diabetes mellitus. This insulin dependent, there is no alternate, we have to go for the insulin, and it is an invasive process, and injection is the alternate. So generally I am not concentrating here because the most of the patients, and as I have given you the statistical data, they are belongs to the non-insulin dependent. So oral medication, I will emphasize on the oral medications. So many of the medications, because we try to avoid this before we get attacked by the insulin deficiency, before that we should identify our blood sugar level and diabetes status and starts the oral medications. Thereby we can sustain our life and live our life in a better way. So oral medications, if you see, there are categorized generally 3 types of oral medications. These synthetic drugs, which include sulfonylureas, biguanides, and the thiazolidinediones. So these 3 category drug, I'll tell you, it may be administered as a single one or maybe in combination with variation in dosage strength. And which case you have to select which one or combination, that we will be discussing later. So here you see the category of the drugs. There are some examples coming under the sulfonylureas include glimepiride. It may be administered 1 to 4 mg once daily, depending on the cases. The physician has to decide, or you can suggest. And the glyclazide, it's 40 to 320 mg once daily. Then glibenclamide 2.5 to 20 mg once daily, or glyphosate, it should be taken 2.5 to 5 mg once daily. Coming to the biguanides, metformin is the best drug. Metformin and fenformin is 500 mg orally 2 times daily or 850 mg once daily. Maximum dose up to 2550 mg per day it can be administered. Fenformin from 200 to 400 mg twice daily orally can be taken. Then thiazolidinedione, pioglitazone is the best drug. Under thiazolidinediones, 7.5 to 60 mg per day can be administered. Now look to this figure. So as I mentioned, 3 category of the drug. These 3 category of the drugs, where it is acting, when it has to be administered, and what is the role of pharmacist here, I can explain you. Thereby this pharmacist importance you can feel, and they can decide your right drug, right choice of the drugs for the right type of diabetes. Now you see, dietary complex carbohydrate, by the glucosidase enzyme, it goes to the blood in the form of glucose. It converts to the glucose. Now this glucose has to be converted into the ATP to be utilized by the tissues or the organ for the organ function. Now these functions, this conversion from glucose to metabolism of the glucose to ATP depends on the insulin, which is secreted from the beta cells of the isolates of Langerhans of pancreas. Sometimes these pancreas, the beta cells are in damaged conditions. In that cases, insulin secretion reduced. So in that cases, there is no alternate. We have to go for the administration of the exogenous insulin. You have to give the substitute. In that cases, you have to go for, that is insulin dependent diabetes mellitus, and you have to go for the insulin substitute. But I am going to take you to administer the oral hypoglycemic agents at different stages. Substitute means, in these cases, as I told you, in diabetes, type 2 diabetes mellitus, sometimes beta cells are active but unable to produce sufficient insulin. In that cases, we can stimulate the beta cells to increase the production of the insulin and to be utilized for the particular purpose. Or in some cases, the insulin will be there produced by the beta cells but unable to utilize by the liver cells or the adipose tissues. So in that cases, you have to manage it, stimulate the sensitivity by the cells, liver cells, or by the adipose tissue to utilize the insulin. So in these cases, you see, in these cases, this is called, say, beta cells are there, they are not able to produce the sufficient insulin. So before, it is called preprandial stage. Before meal you have to administer. So sulfonylurea, you might have seen here mentioned, sulfonylurea is coming to existence, and they will take care. Meglitinide and the diazoxide are the drugs which increase the secretion of the insulin by the beta cells, stimulating beta cells. And in these cases, you see, this is the later stage. You will find these biguanides are effective here, means it is prandial stage, liver cells unable to consume the insulin. So thereby these biguanides help in utilization of the insulin by the liver cells. Detailed mechanism I will be coming to individual drugs when I will be explaining later. And here the third category, thiazolidinediones, which may stimulate or act as an agonist to PPAR gamma, this receptor agonist, and helps in sensitizing the insulin to be utilized by the body, the liver cells and the adipose tissues. So thereby it can help in these drugs, can help in, instead of injecting insulin, it can help in managing the diabetes, type 2 diabetes. Now coming to the sulfonylureas, the first generation, there are two generation sulfonylureas. The first generation include tolbutamide, chlorpropamide, tolazamide, and second generation include glyburide or glibenclamide. It is a long acting, glipizide intermediate acting, and glimepiride long acting, and glycazide long acting. So if you see this, the difference in these two generation, here it is a long acting, these are short acting sulfonylureas. So while administering this sulfonylurea, care should be taken in renal impairment, and serum creatinine level should be checked before administration. Dose-dependent hypoglycemia, in cases of dose-dependent hypoglycemia, care should be taken for the elderly person. Eventually, the oral hypoglycemic agent failure is most likely due to the failing of the beta cells functions. So you are stimulating the beta cells. The mode of action, if you see in detail, sulfonylureas, it blocks the ATP sensitive potassium channels in the isolate beta cells membrane, then reduce the potassium efflux and depolarization and opening of the voltage dependent calcium channels, which gives entry to the calcium into the cell, promotes insulin exocytosis and release. And if you see extra pancreatic effects it produce occurs in chronic or long-term dosing and increase insulin receptor numbers, and sulfonylurea also appear to reduce serum glucagon levels. So adverse effect of sulfonylurea include hypoglycemia, weight gain, and GI symptoms include nausea, fullness, bloating, and hepatotoxicity, allergic reaction may occur. And sometimes if you are consuming with alcohol, disulfiram like action, maybe antabuse like reaction it may produce. So contraindications of the sulfonylureas include type 2 and diabetes mellitus. It won't work for the type 1 diabetes mellitus. Pregnancy or breastfeeding, documented it should not be administered. Documented hypersensitivity to sulfonylureas, and severe hepatic or renal dysfunction, then severe acute illness, it should not be suggested. Then meglitinide, another category. This is first ripaglinide invented in 1998, the first agent, and newer agent it converted to netaglinide. These are short-acting insulin secretagogue that binds to a different site with the sulfonylurea receptors. This work by regulating potassium channel closing, no reaction on insulin exocytosis, so quicker action and shorter duration than the sulfonylureas. Thus, effective in taken just if taken before meal. So preprandial it is effective. It has a shorter half-life than the sulfonylureas and is rapidly absorbed from the gastrointestinal tract with peak levels within 1 hour post-administration and eliminated within 4 to 6 hours. So it should be taken within 10 minutes before main meals and can be added with also other oral anti-diabetic drugs except sulfonylureas. It is primarily used to control the postprandial hyperglycemia. Adverse effect include it is associated with less risk of weight gain compared to the sulfonylurea, and hypoglycemia may be less frequent. Contraindication, this is a higher risk of prolonged hypoglycemia when ripaglinide is combined with gemfibrozil. This combination is contraindicated, so hypoglycemia is the major unwanted side effects. Coming to the another category, alpha glucosidase inhibitors. These alpha glucosidase inhibitors like acarbose reduces the rate of absorption of the polysaccharides in the proximal small intestine by inhibiting the alpha glucosidase enzyme. So they should be taken with main meal. So potential for this prevention in pre-diabetic subjects, it lowers the postprandial glucose without causing hypoglycemia. it is less effective in lowering glycemia than metformin or the sulfonylurea. So the commonest side effects are bloating, abdominal discomfort, diarrhea, and flatulence. So advice is to the patient on acarbose to take glucose, not sucrose, for hypoglycemia if suddenly occurs. Then biguanide. So metformin is a very good drugs coming under the biguanide. Still it is in practice. The mode of action is not understood fully, but still it found to be decreases hepatic gluconeogenesis, may increase insulin stimulated glucose uptake by skeletal muscle. It is a drug of choice for overweight subjects because of action useful in type 2 diabetes patients on insulin, can further lower the HbA1c. Then it is eliminated entirely by the kidney in unchanged forms. Contraindication of the metformin includes renal impairment. So patients should be excluded in therapy if they are suffering from renal impairment, because it eliminated through the renal pathway. So significant hepatic disease, alcohol abuse, then the congestive heart failure, then acute or chronic metabolic acidosis and history of lactic acidosis. So in that cases, it should not be suggested, and caution adequate renal function should be measured in the patients over the age of 80 if they are going to consume this metformin. Then thiazolidinediones, you see, these are the peroxisome proliferator activated receptor gamma and agonist, and act primarily by increasing the insulin sensitivity in muscle. Previously, I explained in that figure, sensitivity in muscle and adipose tissue and liver. So it improve in glycemic control may only be seen after 6 weeks with maximum effect at 6 months. They can be combined with other oral antidiabetic drugs, and the use of thiazolidinediones as first-line therapy has been found to have greater durability in glycemic control compared to metformin and sulfonylureas. Now, contraindication for the thiazolidinediones, it not suggested in type 1 diabetes mellitus and pre-existing hepatic disease or severe congestive heart failure or history of hypersensitivity to the thiazolidinediones. So precaution drugs must be metabolized. Drugs are metabolized by the cytochrome P3A4. So side effects include weight gain. Generally, it causes weight gain due to redistribution of the body fat, and fluid retention, heart failure, macular edema, and osteoporosis. So these are some of the side effects. Now coming another one category is the gliptins. So the gliptins act as a selective inhibitor of the enzyme DPP4, means dipeptidyl peptidase 4, to enhance endogenous incretin level and activity. Incretin is what is incretin? It is a hormone are secreted from the intestine in response to meal digestion. One of their key action is to increase the glucose-induced insulin secretion. So when we take before food, we feel hungry, it will secrete and give stimuli to release the insulin by the isolates of Langerhans or pancreas, and by the pancreatic isolates. So this thereby reducing the prandial glucose excursion. So in the prandial, if it is not giving properly, it should be substituted, thereby prandial glucose level, it will increase. So the sitagliptin in 2007 find out, and the vidagliptin in 2008 were introduced in several countries. Another DPP4 inhibitor, saxagliptin, has recently been introduced in 2009. So sitagliptin is taken once daily in 100 mg dosage strength in the morning, and vidagliptin is usually twice daily in 50 mg dosage strength. Lack of weight gain makes gliptins suitable for overweight and obese patients, and low risk of hypoglycemia when used as a monotherapy. Now coming to the category, another category of the drug, sodium glucose cotransporter 2 inhibitors. So these class of drugs selectively inhibits the SGLT2, a transporter in the proximal tubule, thus reducing glucose reabsorption, leading to an increase in urinary glucose excretion. So if you are hypoglycosuria, you are suffering from, then this category of the drug is suggestible. This is accompanied by the weight loss and modest blood pressure reduction together with lower risk of the hypoglycemia. It is not recommended for those on concomitant treatment with the loop diuretics. If you are taking the diuretics, then it is not suggested. Efficacy of SGLT2 inhibitor is dependent on renal function. So it is not recommended if EGFR level is less than 60 ml per minute per cubic meter cube, 1.73 cubic meters. Then examples: dipagliflozin and canagliflozin and empagliflozin. These are the drugs, category of the drugs belong to sodium glucose co-transporter 2 inhibitors. Side effects include significant increase in urinary tract infection and genitalia infection. So these are the side effects. You have to be very careful. Then glucagon like peptide 1 receptor agonist. These augment the glucose dependent insulin secretion, reduces the glucagon secretion, slows the gastric emptying, and decrease appetite. These category drug examples: exenatide and the liraglutide. So exenatide and liraglutide, the two drugs coming under this category. It is effective in lowering hemoglobin A1C. Approximately, this is the main important criteria to be controlled. So it is very effective to control this, and promotes weight loss in type 2 diabetes mellitus, and administered as twice daily injection. So side effects include nausea, vomiting, diarrhea, and the headaches. So these are some of the anti-diabetic principles, the synthetic agents, and can be prescribed to control the diabetes. And you have to choose looking to its action and the patient suffer from which type of diabetes, whether preprandial, prandial, or postprandial symptoms. So accordingly, you can choose a single or a combination of the drug, suitable combination of the drug, and can manage without insulin if your beta cell can be stimulated to produce, or beta cell produce the insulin, but it is unable to utilize by the adipose tissues or the liver cells. In that cases, these are the best practice, and you can choose the drug and manage. So in India, we are also for practicing the Ayurveda system of medicines, and herbal remedies also. We practice lot of herbal remedies come out to the market and found potential in managing the diabetes. Particularly, these are effective pre-diabetic cases and type 2 diabetes mellitus cases. So along with the synthetic drugs, or maybe alone, if the symptom is not severe, it can be managed, then it is best suggested some of the herbal products to manage the diabetes, and with exercise, or say non-synthetic drug or non-oral hypoglycemic agent, you can manage with this. So if you are having the family history of diabetes, or early detection pre-diabetes cases, so sometimes we suggest some of the herbal formulations. These are also marketed formulation available with different companies in India. They produce in the form of gels, in the form of syrups, or in the form of tablets, or in the form of capsule. There are different types of anti-diabetic herbal formulations, but I'll tell you 3 herbal formulations which are found to be very effective, even though 1-2 of my publications also comes interdisciplinary research, like Gymnona sylvestre found to be very effective anti-diabetics, aloe vera and aloe vera barbadense. So these are the plants. You see, aloe vera contain the barbaloin and amiodarone, and maintains glucose homeostasis by controlling the carbohydrate metabolic enzyme, and stimulate the increase the insulin secretion by the beta cells. Gymnona sylvestre also contains gymnamic acid. Also, it acts as it's a very good anti-diabetic, also antioxidant property. It is having very good antioxidant property to maintain the tissues healthy and its level. So it also widely can be utilized. And Tinospora cordifolia, this is called guruchi in India. Then Tinospora is its chemical composition. It has found that administration of Tinospora cordifolia root extract to alloxan induced diabetic rate found a significant reduction in blood glucose and lipids after oral administration of its root extract for the 6 weeks. These are the references from the journal mentioned below. So these combination or formulation or alone in the form of syrup or maybe tablet or capsule can be utilized along with the other oral antidiabetic synthetic analogs, or without, or with the exercise and the controlling the food habit or diet, so can manage best way the diabetes, type 2 diabetes mellitus. So these are the remedies, and it can best way practice, and pharmacist can choose a proper medication and suggest the proper diet and suggest the proper exercise. If they control the blood glucose level to identify the biochemical level to identify the diabetic stages, and help in the patient, help the patient in choosing a drug, right dose of the drug at right time to sustain a healthy, sustain and improve a quality of life for the diabetes patient. So with this, I conclude all of my presentation today pertaining to the management of diabetes by the help of pharmacist. So these are the references one can follow to know about how to manage the diabetes. And then I am very much lastly thankful to the audience for patience listening. And now time for question. Thank you all for giving me the opportunity to stand before you and share my thought and share my knowledge with you. Thank you. Thank you all. Thanks the audience and the participants.
Okay.
Sir.
Thank you very much, Prof. Binder.
Thank you, sir.
Thank you very much. We have two questions for you. All right, so let's get to it. The first question says that metformin XR has been recalled by some manufacturers, and they will be grateful for your comments, please.
Shall I go to my slide?
You mentioned the role of metformin in oral as an oral hypoglycemic agent to control the blood sugars. So someone is asking about metformin XR because it has been recalled by some manufacturers. So
Yeah.
they just wanted to get your comments on that, please.
These are the established pharmaceutical products available throughout the world to manage the diabetes. And this alone, as well as metformin and the glimepiride, sometimes can be utilized to control immediate release. It can help in periprandial controlling the diabetes. And along with also for sustainability, glimepiride also can be given. Glimepiride is a long acting, so along with also can be prescribed.
Yeah. All right. Well, just to add to that, that there has been some contamination with higher than normal levels of NMDA that has been linked to metformin, and probably that is why some of the preparations have been recalled. Right. The second question is, what are the preventative measures for diabetic patients, especially after the post-COVID-19 pandemic situation?
Yeah, after during the COVID-19 pandemic situation, it has found that due to stress conditions, diabetes level all of a sudden raised for the COVID-19 positive patients. In that cases, immediately to control, we go for the insulin therapy, because you know these oral anti hypoglycemic agent, it takes time. Sometimes it requires the month together, week or months together in continuation to subside. So immediately we have to go to control this by the substitution with the insulin therapy. Then once it controls to a level, then we can continue the oral hypoglycemic agents in the sustaining the life. So after post-COVID era, after post-COVID, they can manage with the oral anti-diabetics agents. Maybe sulfonylurea and a combination of the with others. Widely we use sulfonylurea first stage.
Okay, great. All right, thank you very much, Prof. Tinder, for that very exciting presentation. We learned about the goals of diabetes management. We also learned about the role of the pharmacist. You looked at in depth at the non-pharmacological measures as well, and the pharmacology of the drug classes that are used to treat diabetes. So I'd like to thank you very much for that.
Thank you, sir. Thank you for giving me this
Yeah.
opportunity.
Dr.
Thanks to the
Dr.
participants.
Satish.
All right,
Uh,
so
Dr. Satish.
just to let you know that this webinar has been accredited by the American Association for Continuing Medical Education. So in case you're interested in CME credits for attending this webinar, there is a link that is posted in the chat box. You can click on that link for more information with respect to CME credits. So our next speaker is Professor Suraj Singh, and for those of you who don't know who Dr. Suraj Singh is, perhaps you have been away from this planet for a little while. I remember I had the honor of being a student in his clinic when I was a pharmacy student, and one of the things that I really admired about him was that he treated us basically the same way that he would treat the medical students. We got the same difficult questions, we got treated the exact same way, and it helped us really to develop into better healthcare. So, Professor, and one other thing I remember as well, when I was there, one of his students asked me, he said, why do you think Dr. Tiloxing does not put his qualifications on the door? And I said, I don't know. And he said, there's not enough space on the door for him to complete all of his qualifications. And I guess we'll probably have to get a much bigger door for him now. So Professor Suraj Tiloxing is a professor of medicine in the Department of Clinical Medical Sciences in the Faculty of Medical here at the UWI. He specializes in internal medicine, diabetes, and endocrinology, and he also chairs a cabinet-appointed technical advisory committee that reports to the Ministry of Health of Trinidad and Tobago on strategies to combat chronic diseases. He was also instrumental in producing a monograph on dengue hemorrhagic fever and dengue shock syndrome on behalf of PAHO and the World Health Organization. With respect to he developed the Pediatric Endocrine Service and strengthened the super-regional adult endocrine clinic in the School of Medicine at Mount Hope. In academia, he has developed and introduced the objective structured clinical examination as the concluding examination method at the UWI's Faculty of Medical Sciences. He has also led the university in implementing medical examination formats in keeping with internationally accepted standards, developed a curriculum for public education in diabetes. Professor Tiloxing has over 120 published articles, which has attracted close to 20,000 reads and over 1,500 citations. His work has been published in numerous high-impact, prestigious journals. He's a fellow of the Royal College of Physicians of Edinburgh in the United Kingdom, and he has served previously as the president of the Medical Board of Trinidad and Tobago. So we shouldn't keep you waiting any longer. I now introduce to you Professor Suraj Tiloxing.
So thank you very much for those very kind words of introduction, Satish. I'm delighted to be part of this panel, and the previous speakers have made my work infinitely easier because they have set the tone. We've heard from the president of the Diabetes Association on the prevalence of the disease in Trinidad. And we've heard from the professor from India, Professor Binder, on how we manage diabetes. And my presentation is going to be really quite short. If I can get my screen to be displayed. Is it being displayed, Satish?
Not just yet, Prof.
Okay, so let's get that up. It says I am screen sharing. Am I on?
Yes, you are.
Beautiful. So the tone has been set, and I will simply, over the next 10 minutes or so, outline a strategy for intervention. You know, it was alluded to that Trinidad, since the 1960s, had the highest prevalence of diabetes in the Western Hemisphere. And we've continued to occupy that #1 spot. There's a little bit of jostling, and Guyana is coming hot on our heels. And the commonality between Guyana and Trinidad is the fact that half the population in Trinidad and Guyana come from the Asian continent, the sub-Indian continent. India is leading the world per capita just about now, and China is hot on their heels. So for direct comparison, China is number one and India is number two. But that competition, we have led for a long time in the Western Hemisphere. And what I'm going to talk about is really a strike against diabetes and intervention that begins in the womb. And as we commemorate World Diabetes Day and put the nurse at the epicenter, the nurse-midwife at the epicenter of diabetes management, this is a call that this really is a group effort, and pharmacists, doctors, dietitians, people like the Diabetes Association ought to be rallied in this intervention that I'm going to talk about. And I'm calling it a strike against diabetes in the womb. Now, HIPTT refers to essentially hyperglycemia, raised blood sugar in pregnancy in Trinidad and Tobago, and expanded into the generic term of health in pregnancy, Trinidad and Tobago. And I am very happy to report that the Ministry of Health, under the auspices of the Directorate of Women's Health, ably led by Dr. Adesh Serju Singh and his team, are about to partner with our group, the Health in Pregnancy Trinidad and Tobago, to deliver a 2-year intervention targeting diabetes in pregnancy. I'm going to share some generic ideas, some general ideas, and throw out a clarion call for all in this conference and all of those who will witness this via on-demand service to join with us as we target diabetes in pregnancy. So let's start our slideshow. I'm having a little difficulty here, guys. Forgive me.
Just advance your slides with the arrows at the bottom of your screen.
Right, here we go. Our story starts in 1824. Trinidad was under a surge of immigration from Venezuela, much like it is today. As you may know, those of us who are international, who may not be aware of the culture in Trinidad right now and the socioeconomic environment, hundreds, if not thousands of visitors are entering our shores from Venezuela because of political unrest. And this was the case in 1824 as well, when a gentleman by the name of J.G.B. Seagard came across, fleeing the chaos in Venezuela, and set up a distillery, a rum distillery in Trinidad and Tobago. This rum is still being produced, and 1824 commemorates that year that he came to Trinidad and produced his first rum. But in another part of the world, something else was happening. In Germany, a case was described in the literature of a pregnant woman who had classic symptoms of diabetes, as described by our professor from India: excessive thirst, excessive urination. And not surprisingly, this occurred during her pregnancy and caused the baby to grow so large that she had difficulty with labor. And true to form, that baby was born so large, experienced birth trauma, and died soon after birth. That was the first case report of gestational diabetes mellitus. And that too occurred in 1824. Oh, I'm having trouble advancing again. There we go. So I'd say, folks, the word is not RUM, rum. It's GDM, gestational diabetes mellitus. And I'm just going to walk us through what gestational diabetes mellitus means and how we're going to attempt to solve the problem. At the end of this session, I'd expect you to know that gestational diabetes is the commonest medical problem in pregnancy, to understand that you cannot look at a pregnant woman. Though there may be some markers, you will only get it right in 50% of the time if you were to attempt to diagnose it clinically. You will have to do a glucose tolerance test to diagnose it. And I'd like you to also understand that there is a difference between diabetes in pregnancy and gestational diabetes, but it's only a subtle difference because it's a question of degree. Diabetes means higher levels of blood sugar, and I'll show you what the definition is, whereas GDM means slightly lower levels, but still increased risk of problems. And I'd also like you to know that treatment is effective for gestational diabetes. The womb is often seen as a safe and secure place. Nothing could be further from the truth. A baby in the womb exposed to high blood sugar just barely above the normal range is at increased risk. Increased risk in the near term, increased risk in the medium term, and increased risk in the long term. Not only is the baby at risk, pregnancy is a stress test. And the pregnant mom who expresses diabetes in pregnancy or gestational diabetes mellitus is at increased risk for diabetes and cardiovascular risk in later life. So let's just see what those short-term risks are. In the short term, raised blood sugar in mom leads to extra glucose being delivered across the placenta to the baby, which causes fetal macrosomia. The baby grows larger than the baby should grow. Not only that, the baby grows large, but remains relatively immature. So date for date, a baby of a diabetic mom has immature organs, maybe larger than normal, but have immature organs, and is therefore prone to a host of problems. High blood glucose in pregnancy increases and doubles the risk for cesarean section. High blood sugar early on during the organogenetic phase of fetal development, embryonic life, the first 12 to 13 weeks, imposes an 8-fold risk of fetal abnormalities, particularly of the brain and nervous system and the cardiovascular system. In later pregnancy, raised blood sugar increases fetal growth, and that increases the risk of navigation through the birth canal with a 3-fold increased risk of birth trauma. And after birth, if sugar is not controlled closely during pregnancy, especially during parturition, there's a high risk of neonatal hypoglycemia, low blood sugar requiring infusion of glucose. And that in turn requires neonatal ICU, which increases separation from mom and increased risk for treatment and supervision, so all adding to increased costs. So those are the medium term, the short-term risk. In the medium and long term, as I've explained to you, not only is baby at increased risk for diabetes, mom is at increased risk for diabetes. Not only is baby at risk for cardiovascular disease, mom is at increased risk for cardiovascular disease. And you must always remember that diabetes and cardiovascular disease are flip sides of the same coin. Patients with diabetes are at increased risk for cardiovascular demise. The leading cause of death in diabetes is cardiovascular disease. Diabetes appears second or third on the death certificate. Heart attacks, strokes, kidney failure, peripheral vascular disease will appear first. And I just want to show you the implication of high blood sugar in pregnancy. This is a family of diabetes. Mom had gestational diabetes. Mom shown on the right had gestational diabetes. Baby is age 8 in the middle, already with type 2 diabetes, who was discovered during a routine screening program that we instituted in schools, and her blood sugar was found to be 400. That's 4 times what your blood sugar is after a very hearty lunch. So there is this intergenerational spread of diabetes. A mom with diabetes exposes the baby to high blood sugar, which programs epigenetically an increased risk for the child developing diabetes. You will also note that this baby was quite big. And as I alluded to earlier, where obesity leads, diabetes follow. And the diabetes epidemic follows the obesity one. And it's no chance. In the current infectious pandemic, the interplay and overlap between diabetes, obesity, and COVID-19 has been immense. The people at highest risk are not just men, but those who are overweight and have the comorbidities of diabetes. So there's a huge interaction between the current pandemic and the pre-existing obesity diabetes pandemic, and that's now referred to as synchronous pandemics or syndemics. And one revealing the vagaries and the difficulties with the other. Now, how prevalent is gestational diabetes? You may not be able to read much of what's in this slide, but let me walk you through it. On the y-axis is the prevalence of diabetes, and the top level is 30%. No country currently reaches 30%. But you'll see Singapore on the extreme left, and shown in red is the number one country for gestational diabetes in this chart. I want you to know Trinidad and Tobago has much the ethnic composition of Singapore. South Asian derived, Chinese, Malays, and people from the Indian subcontinent. We have a similar kind of mix, as does Guyana. So why does Trinidad, shown here, have a 6% prevalence when Singapore has a 25% prevalence? It's because we are measured in blue and they are measured in red. And the various color schemes here are telling us how the study was done. You cannot compare apples, grapes, and lemons. If we use the same methodology, Trinidad will not be 6%. We'll be in the league of Singapore, 22 to 25% prevalence for gestational diabetes. So it was really a methodological difference that put us in the low category when Singapore is in the high category. Sorry, I went backwards. So I'm going to build a pyramid with what I've said before and show you how this plays out. The PAHO STEP study was referred to by a previous speaker. It was conducted between 2011, 2012, published in 2011. And that showed something really interesting. Women of reproductive age group, and for definition, I'm saying 15 to 44 years, that's arbitrary. But if you take women 15 to 44 years, 65% of them were combined overweight or obese. In Trinidad and Tobago, 65% of our women in the reproductive age group has a combined overweight obesity prevalence of 65%. It was already alluded to, if everybody is overweight or obese, you don't recognize it. And that may be the problem here. But when there is overweight and obesity among female, reproductive life becomes difficult. Not only is fertility reduced, but when an overweight or obese woman becomes pregnant, there's increased risk of gestational diabetes or frank diabetes, and pregnancy-induced hypertension, and a higher risk to the fetus. And we screened pregnant women across 3 clinics in Trinidad and Tobago a year or 2 ago, and we found impaired glucose tolerance in 16 to 22% of them, depending on where we looked. That's a pretty high number. And compared with the historical data of 6%, there was a mismatch. And as I've explained to you, it's simply because of the methods. The method currently used to diagnose gestational diabetes is a long name, IADPSG. A study group published its data in about 2011, 2012. And if you use that criteria rather than the World Health data, we are really 22%. I'll show you that in more detail just now. In simple numbers, Trinidad and Tobago we expect 20,000 deliveries a year, 20,000 pregnancies a year. And of those, based on our data, 1,000 of those 1,000 of those moms will have diabetes that's pre-existing. That's not gestational diabetes, that's pre-existing diabetes. But another 3,000 of them will develop gestational diabetes because of the hormonal stresses induced by the pregnancy. The placenta produces hormones that oppose insulin and will bring out, through a stress response against insulin, hyperglycemia that could be defined as gestational diabetes based on some criteria I'll show you just now. In other words, 4,000 of 20,000 will have some form of dysglycemia, raised blood sugar in pregnancy, incurring the wrath that I've described before. That's the summary page. Oh, I'm going backwards, I'm sorry. This, I apologize, bear with me. This figure helps to illustrate a definition that I'd like you all to bear in mind. Any value above the red line means diabetes. So if you're fasting and your blood sugar is greater than 126, or your 2-hour postprandial sugar is greater than 200 on venous whole blood, you are described as having diabetes by the World Health Organization. So if you have classic symptoms and your fasting blood sugar is greater than 126, you have diabetes. If you have symptoms and a random blood sugar is greater than 200, you have diabetes. Or if you perform a glucose tolerance test, as this does, you have diabetes. Whether or not one is pregnant, this is the definition of diabetes. So if during pregnancy you have a glucose tolerance that looks like this red line or above, you are said to have diabetes in pregnancy, whenever that test is conducted. Upon pregnancy, during pregnancy, after pregnancy, before pregnancy, that's diabetes. If during pregnancy, on the other hand, you have a fasting value greater than 92, but less than 126, a 1-hour value greater than 180, or a 2-hour value greater than 153, but less than 200. In other words, in this gray zone here, you are defined as having gestational diabetes. And that's the difference between diabetes and gestational diabetes. What does it mean for risks? The risks are similar, but the scale is increased. Diabetes will have a higher risk than gestational diabetes, which will have a higher risk than those who are normal. So it's a question of degree. For this reason, you cannot look at a lady in pregnancy, whatever her age, whatever her family history, whether she has acanthosis nigricans or not, whatever her previous pre-morbid history, and say she has gestational diabetes or not. You've got to do a glucose tolerance test. That is now the gold standard. It's a 75-gram glucose tolerance test done after an 8-hour fast, and these values would categorize you as either normal, GDM, gestational diabetes, or diabetes. That was one of your learning points when we started. And many expert organizations across the world have now been motivated by this new definition, which is evidence-based, and for which the history of GDM has been very confusing, and I won't go through it. It's because we were using different standards, different protocols, 1 steps, 2 steps, like 50-gram glucose, 75-gram glucose, 100-gram glucose to do GTTs, and we were doing it somewhat arbitrarily. Data from the HAPO study and the IADPSG study group suggested these guidelines that I just showed you, and many expert organizations have got involved, adopted them, including the ADA, WHO, etc., and including us in Trinidad and Tobago, where diabetes guidelines in pregnancy have now been set up. And it's based on these guidelines that we are rolling out this program over the next 2 years. I don't call it research, I call it activism. And this activism requires all of us. It requires everybody in the community, pregnant women, their families, the diabetes associations, nurses, midwives, pharmacists, dietitians, lay people. This has to be a movement. It has to become a social movement. It has to become an educational movement. It has to be a high priority if we are to make a strike against diabetes. Because treating diabetes in the womb not only has the potential to reduce immediate the short-term complications I told you about, the overgrowth of the fetus, the need for neonatal ICU, the need for forceps delivery or cesarean section. It also will reduce the potential risk for obesity and future diabetes and cardiovascular disease. Now, I told you 1,000 women will be entering pregnancy with diabetes. I think it's important for us to do pre-pregnancy and inter-pregnancy testing. And one of my students has developed a screening tool for us to employ. It may well go on the Diabetes Association website and their app for patients to screen themselves before they get pregnant. You know, if you have fertile soil, you get good crops. If we wait for diabetes to be discovered during pregnancy, the horse is bolting. We've got to diagnose you before you get pregnant. And if you do get pregnant, we must screen you early as we can, during the early periods of fetogenesis, embryogenesis, when the baby is developing his or her organs. And we must repeat that glucose tolerance test between 24 and 28 weeks, because this is when gestational diabetes rears its head. So pre-pregnancy counseling and early pregnancy testing will diagnose pre-existing diabetes, and testing between 24 and 28 weeks of pregnancy will diagnose gestational diabetes. Treating both makes a difference. One other little plug here for a simple drug that is cheap and effective and to which most of us will not react adversely, and that's aspirin. Aspirin used from the 13th to the 36 weeks of pregnancy has the great potential in gestational diabetes and diabetes to reduce the risk of pregnancy-induced hypertension and eclampsia. If any one of you has ever experienced an eclamptic pregnancy, either through personal experience or by your participation as a husband or a relative, you will know how nasty that disease is. And aspirin has the potential. Good old aspirin, discovered thousands of years ago and introduced into medicine formally by Hippocrates, makes a big impact on that. So simple measures that we could all use, whether you're a pharmacist, whether you are a layperson, whether you are a volunteer with the Diabetes Association, whether you're a physician, whether you are a nurse or midwife, simple interventions could have small biochemical and pharmacologic intervention, could have huge clinical outcomes. And that's really the activism we want to generate. Really, the strategy is straightforward. This is not rocket science that we are proposing to the Ministry of Health and the Directorate, and that's why they're buying this philosophy. It's about standardizing the protocol, using a standard accepted protocol that's evidence-based, using it across the board, private sector, public sector, across geographic regions. It doesn't matter whether you receive your care from the private sector, which 30% of people do, or the 70% of being offered care in the public health sector. Everyone, irrespective of ethnicity, race, socioeconomic background, private sector or public sector, should receive the same treatment. We'll be developing a learned management system from which doctors, pharmacists, nurses, midwives will have on-demand access. We'll be training the trainers, and everyone can go on, log in and access our material and train to become volunteers, experts, update your medical education, do CMEs and get registered through the Medical Association of Trinidad and Tobago. That's essentially it. And what's more, we hope to introduce electronic health records in pregnancy. That has been long in coming. Electronic health records, for all its negatives, has important value for access and accessibility of information. If, as part of the mandate here, is to develop an electronic health record starting in pregnancy, remember there are 20,000 pregnant women a year and 20,000 deliveries. That's 40,000 Trinidadians with the start of an electronic health record. Just think about the impact in 5 years. So it's not about training and continuing medical education. It's about developing online systems. It's about developing electronic health records. It's about universal access, all of which are in keeping with the Sustainable Development Goals of the United Nations. Ladies and gentlemen, we do have a problem. We have had this problem. As I've said, Trinidad and Tobago has been the forerunner in the hemisphere with diabetes. Now is the time for us to make a strike against diabetes, and we're starting at source. We have a problem, but together we can create a solution. I thank you for your time, your future help, your future energies, and your future participation. Thank you for allowing me this forum to share our ideas. Thank you so much.
Thank you very much, Professor Tiloksing, for that presentation. It was very exciting. It gave us a lot of information, a lot of relevant information with respect to diabetes and gestational diabetes and how significant a problem we have. And we really all need to work as one unit to combat this problem. Right. So thank you again very much for that. If we look at some questions now, just to let you know again that the CM, that this webinar is registered for continuing medical education. The email address there for you in case you are interested. All right, so let's look at a couple of questions. We have one for Professor Tiloksing. Can you comment on raspberry tea leaf effectiveness in diabetes?
So I really don't know about this intervention. And if anybody, especially our prof from India, knows anything about it, I'd be grateful if he could help me out here.
Prof Dinda, we have another one for you. It's raspberry leaf tea is one, and the other one is jamun.
Yeah, jamun is effective. Jamun is found to be effective. Jamun bark and extract of the bark found to be, but I don't have idea about this first one which you asked, the raspberry tea leaf.
Okay.
Can I truly?
Moringa is very effective. Moringa tea leaf is very effective, found to be. Even though Ethiopia also they practice moringa tea leaf, is very effective, found to be.
May I inquire through the chair, what is jamun?
Oh, jamun.
Guava leaf. Guava, that bark. Jamun means in India we call jamun.
I'm seeing the scientific name is Syzygium cumini.
Okay.
It is not guava.
Means?
Jamun is different. I have seen in Trinidad and Tobago also.
Okay.
I have tasted it, but I can't explain. I have given the scientific name and.
So, Dr. Dahiya.
Maybe yeah. Arjuna. This is Arjuna.
No. It is not Arjuna. The scientific name I have mentioned here. Okay. It is Syzygium cumini.
Okay.
At presently, I only know the location. My son was studying in Vishnu Boys Hindu College in Karoni, and there were some trees, and I ate from those.
Okay. I don't have that idea.
All right, so we have another question. This one is for Professor Dinda. Yeah. How do the different categories of drugs act in different stages of diabetes?
As I told you, there are different categories of the drugs. First I mentioned the sulfonylureas act as different stage, like pre-prandial stages, And then it comes the second category of the drugs, thiazolidinediones, that postprandial effective. So like that, there are different stages also. I mentioned some of the drugs like prandial stages. So already I mentioned the different categories, how it is affecting to control the stages, different stages of the diabetes because of different regions.
Okay, thank you very much for that. For Mr. Danu, we have one question for you. If I want help from the Diabetes Association of Trinidad and Tobago, how can I get it?
So you can reach out to the association at any time. Again, on our social media pages, Facebook and Instagram, and also uh, at the to Diabetes Association. Um, Phone number 6720864 and or email address, which I'll put in the chat. So at any time you can reach out to us, and of course, based on the area that you are at, we'll either direct you to our nearest branch, or if we need to deal with something at the head office, we'll do so, or direct you to some other medical institution if you need that type of help.
Okay. Thank you very much, Andrew. We have one final question here. Would medications derived from natural bioactive polypeptides be preferred over synthetic drugs for the treatment of diabetes? I know we have an expert in natural bioactive polypeptides on the panel. Dr. Dehia, would you like to take that question?
Yeah, that actually that is asked from my research group students only, as they are going for the survey of that. I know that there is a lot of research on peptides which are used in the treatment of various diseases, but on diabetes there are less which are not yet reached in the stage where in the market, or they have passed the clinical trials. I know some of the polypeptides which are helpful for known for their antimicrobial action, like polymyxin B, that is currently used, polymyxin B, colistin A. These are helpful, but I'm not sure about diabetes if polypeptide is there in market. I think more expert advice is needed regarding this.
All right,
Thank you.
thank you. Thank you very much for that contribution. I'm not seeing any additional questions being posted at the moment. So if there are no further questions, I would like to thank all of the presenters, Mr. Andrew Danu from the Diabetes Association of Trinidad and Tobago. You're doing wonderful work as usual, and I wish you continued success in that. I'm sure that you will have a lot of people from the School of Pharmacy and from our student population who would be interested in contributing towards the efforts that you are making. To Professor Dinda, again, thank you very much for your insight into all of the treatments of diabetes and especially the pharmacological and non-pharmacological methods of treatment. And to Professor Tiloxing, thank you again for that very insightful, brilliant presentation about how things need to change in order to manage diabetes in the Caribbean. And probably for showing us as well that the graphs and the slides that we may often see where we are not the front runners in the diabetes incidence, we really need to take a close look at that and make some adjustments to our lifestyles and modify how we do things here locally to improve diabetes and its management in our patients. Right, so with that in mind, I would like to thank you very much, everyone, for attending, to all the attendees who came to this webinar that has been put forward by the School of Pharmacy. Thank you again for your support. And we would look forward to you joining us in the future, where we would like to have more educations like this one to promote knowledge among the local pharmacists as well as our health professionals. All right. So thank you again very much for your
Thank you too.
attention. Thank you
Thank
very
you
much
all.
for your contributions. Thank you very much.
Thank you. Thank you. Good night.
Take care. We'll see you